one of the doctors in the medicine clinic for today. May I confirm that you are Mrs. Mona and you are the daughter of Mr. Ali? Mr. Ali is 70 years old.
Yes, doctor.
Mrs. Mona, today we are here to discuss about your father's health condition. Is it okay for you?
Yes.
It came to my knowledge that he's having some problem regarding the control of his water work. Can you tell me more about it?
Yes, doctor. Now for 1 year, my father can't control his water work, and
Mm-hmm.
this making him very shy, and he's now not leaving the home at all because of this problem.
Okay, I'm very sorry to hear this. Since how many
One year.
days? Since how long?
One
One
year.
year.
Yes.
And what do you mean exactly? But he's not able to control it. Is it like he is not able to hold himself? Like the urine when he want to go to washroom, he gets some drops of urine, or he's totally unable to control.
No, no. He can control his water work, but when he is having the sensation of this water work, he can't reach the bathroom, and sometimes he miss some water work.
Oh, okay. You mean when he is going to the washroom, some urine will go out.
Yes, yes, yes,
Okay, but he get the feeling to go to washroom.
yes,
Okay. Does it happen in the night time as well?
yes. One time, he had he wet himself when he was sleeping.
Okay, I'm very sorry. Is it painful also, like his water work is
No,
painful?
no, no pain. No,
Is there is any change in the amount,
no. The amount is okay.
the frequency
The frequency increased recently.
increased recently?
Yes.
Okay. Is it the color also change?
No, no, no color change.
Is the urine became frothy?
No fluffiness.
No frothiness. And how is the back passage? Is he able to control his back passages?
Yes, he can control his back passage.
He can control his back passage. Okay. Does he have any tummy pain with this?
No tummy pain.
Tummy swelling?
No.
Okay. And how is Mr. Ali overall? He's doing well at home.
Not that well, doctor. Recently, he's becoming more dependent on us. He can't do
Uh,
his daily activities anymore.
you mean in the body power itself, or he is forgetting the things, or what?
Both. He's become more forgetful recently, and also
Mm.
the activities become more slow.
Okay, okay, more slow. Does he have any like behavior change as well?
Sometimes he's becoming angry. Sometimes he can't remember our names.
Oh, okay.
Okay.
Like which memory? The old memory? You're saying your names.
No, no. More, yes, more of the recent memory, but sometimes he can mistakenly miss our names.
Mm. Does he have also walking issue or gait problem?
Yes, yes. He has recurrent fall, and sometimes the walking is very difficult, become difficult in movement other
Like
than
it's
walking.
going from side to side,
No, no. He having some difficulty in taking the steps.
downstairs? Mm.
Downstairs, I think it is okay, but he had recurrent falls also when walking.
Okay. Does he have any vision problem?
No, his vision is okay.
Okay. And does he have any headache?
No headache.
Any disturbed sleep?
Yes, his sleep is disturbed recently. Yes, he's awaking a
In
lot.
what sense?
He's awaking
Um,
a lot in sleeping. Yes.
okay. Okay. Hmm. Okay. Any stiffy neck?
His body is overall stiff, doctor, but no stiff neck per se.
Okay. His body. Does he see things which is normally not present?
I'm not sure about this.
Any abnormal movement in any part of his body?
Sometimes I can feel that his right hand is shaking.
Is it mainly at rest or activity?
I think it is more at rest.
Okay. Did he ever got a fall?
Yes, doctor, I told you he had recurrent fall.
Had recurrent fall.
Yes, one of
Okay.
them
Did he
when he
ever
was
injured?
hurrying, one of them
Mhm.
when he was hurrying to go to the bathroom.
Okay.
Yeah.
Okay. I'm very sorry for this. Did he ever injured himself?
No, no,
Okay. Okay. And does he have any weakness in any part of his body?
I don't think so.
You don't think so. Okay. Any numbness, tingling sensation?
No, no.
Does he ever diagnose with any health condition?
Yes, he is diabetic and hypertensive, and recently the doctor stopped both medication because the doctor told us that his blood pressure is becoming more low. So the doctor stopped the blood pressure medication. And about the diabetes, he's taking only metformin.
Metformin. How was the last test, which we call HB1C?
I think it was seven and a half.
7.5. Okay. Okay. And does he has any other health condition?
No, no.
Since how long diabetes and high blood pressure?
For a long time, doctor, more than 20 years now.
More than 20 years. Okay. Does he have any, I'm sorry, taking any over-counter medication?
No, no,
Any illicit drugs?
no.
Any family history of similar condition?
I don't think so.
Any family history of any what we call memory issue?
I think my grandmother has dementia.
Has dementia. Okay. And did he had any high body temperature?
Recently, no.
Any weight change?
Yes, he lost some weight recently because of the decreased oral intake. Yes.
Why? Because of no appetite or what?
Yes, yes.
He's having any difficulty of swallowing?
No, no.
Any difficulty of speech?
His speech become more slow. He can't
More
express
slow.
himself
Okay.
as usual.
Oh, okay. I'm sorry. Any lumps and bumps?
No, no, no.
No lumps and bumps. Okay. Any weather preferences?
No.
Dizziness on standing position?
Sometimes, yes.
Okay. Any joint pain?
Some knee pain, doctor.
Knee pain. Okay. This is like because increase with activity?
No, no. This has been for a long time now.
Okay. Any back pain?
I don't think so.
Any awareness of heartbeat?
I don't think so.
Any chest pain?
No, no,
Any breathing discomfort?
no.
Any skin changes?
His skin is, I think, more of greasy, especially his face.
Okay. May I examine him?
Yes, please.
Okay. First, I need to see the patient.
Okay. The patient is normal appearance.
Normal. Can I see where he is having the tremors?
His right hand.
Is it resting tremors?
Yes.
Okay. I need to do synkinesia. I need to ask him to tap on his other limb to see is it increasing.
Yes. Tapping on the other limb increase the tremors.
Increase it and okay. And how is the rigidity?
Okay.
Is
There
that
is
is it hand
Yes, there is cogwheel rigidity on the right limb. About the left limb, it is more of lead pipe.
lead pipe? Okay. And I need to examine at this level. I need to examine his blood pressure sitting and standing.
Yes, there is postural hypertension.
Okay. I need to do pronator drift.
Pronator drift is negative.
Is negative. Okay, I need to do bradykinesia. I need to ask him to try to do with his thumb to do this with fingers.
Repetitive movement with the finger. Okay, there is
Mhm.
bradykinesia. Yes,
There is bradykinesia.
yes,
Okay, okay. Then I need to go to the face. Is the skin is greasy or oily?
yes. There is greasy skin.
I need to offer glabellar tap.
No need, doctor.
I need to do supranuclear gaze. Like I need to ask him to look up and look down.
Okay, there is
Follow
no
my finger.
supranuclear pulse.
No supranuclear palsy. Okay, I need to ask him to say his name.
His name. Uh, my name is Ali. Okay,
Hmm.
continue.
Okay. Thank you very much. Okay. And I need to ask him to write or draw something.
No need, doctor.
I need to examine his gait.
Examine, but try to protect the patient. He's
Mm.
having short steppage gait. It is
Mm.
more slow and interrupted with difficulty in
Okay.
turning round.
Okay. I need to offer mini mental state examination.
A mini mental state examination is reduced.
Okay, and I need to ask Bismillah, I forgot. I need to do a cerebellar test like this
Do,
diadokinesia and
do it, doctor. Do it. There-
I need to okay. I need to check for hypotonia. I need to check for intention tremor. I need
Sorry,
to check
hypotonia. Sorry. Hypotonia.
if any hypotonia.
No. There is rigidity.
Okay, rigidity. I
Yeah.
need to check for any intention tremors, nystagmus, dysdiadokinesia, and rebound phenomena.
Okay. All of this is negative. Are negative.
Mm. Mhm. Okay. Um, then I need to إيه تاني بس خلاص. I need to examine his abdomen because he's having urinary incontinence.
Examine, doctor. Examine. Where you want to examine?
Any organomegaly,
No organomegaly.
any tenderness.
You mean suprapubic?
Yes.
Yes, there is some suprapubic tenderness. Yes.
Okay. Okay. I need to examine the lower limb, if any lower limb deficit.
2 minutes remaining. Okay.
Mm-hmm.
What do you mean lower limb deficit?
Any neurological problem in the lower limb.
Like what sensation? You mean?
Sensation. Oh.
Sensation is okay.
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 Okay, Mr. Ali, can I ask you, Mrs. Mona, can I ask you what is your concern?
Yes, doctor. My concern about this, my dad is becoming not like himself anymore. This uncontrol of his water work, this recurrent fall. What could be the cause? And also the memory problem. Anything could be
Your
related?
your
Yes.
concern is very valid, Mrs. Mona. I think after I spoke to you and evaluating your father's condition, he's having a condition which we call Parkinsonism plus. It is simply when there is damage happen to specific part in the brain, which is we call it basal ganglia. It's a specific part in the brain. When it gets damaged, it causes this kind of symptoms of tremors, rigidity, and sometimes associated with memory issue, control of of his water work. So this is we call Parkinson plus, and we need to run imaging test for him as well as blood test. We will make a group of doctors like brain doctor, high specialized nurse, and kidney doctor, and we will do the blood test as well as the urine test and imaging, and will update you.
Okay,
Do you have any
doctor.
other concern?
Thank you. Time's up. Now discussion with the examiner. Present your case and your positive finding, please.
Mr. Ali, 70 years old, presented with urinary incontinence since 1 year, mainly with urgency and one-time nocturnal enuresis. On history taking, he's having dementia, he's having rigidity, he's having tremors, and he's having also disturbed gait. On examination, he's having symptoms suggestive of Parkinsonism, plus in the form of rigidity, tremors, resting tremors, positive synkinesia, positive bradykinesia, blood pressure drop, and reduced mini mental state, as well as the presence of urinary incontinence. So my diagnosis is Parkinson plus, can be multiple system atrophy.
You mentioned about multiple system atrophy. What is the clue here in multiple system atrophy?
Autonomic dysfunction.
Anything else rather than the autonomic dysfunction?
البلاد بريشر dropping والautonomic dysfunction. uh,
Okay. Is the patient is having any pyramidal or cerebellar symptoms?
no cerebellar symptoms.
And no pyramidal symptoms. Okay. So it's only
Hmm.
the autonomic dysfunction. Could the autonomic dysfunction be a feature of Parkinson itself?
Yes.
Okay.
Parkinson itself can cause autonomic dysfunction. However, it will not give والله it will give
Yes. Parkinson
يعني هو بس
itself,
باركنسونيزم.
Parkinson itself can give the autonomic. There is
بس مش
extra.
هيعمل له dementia، بيعمل dementia.
Yes, 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 yes. Parkinson itself can cause what we call Parkinson dementia. Okay. So,
Hmm.
but here the clue is to ask: is the dementia preceding the Parkinson's symptoms, or the Parkinson symptoms is
Ah,
preceding the dementia? If the movement disorder is coming first, so this is what we called this is what we call Parkinson dementia. Okay, okay. So,
okay.
what
Mhm.
are other differential diagnoses of this incontinence in this patient?
Can be normal pressure hydrocephalus, where it's a triad of dementia, urinary incontinence, and recurrent fall.
Okay, very good. How to
But against
differentiate?
this
Yes.
patient has symptoms of Parkinsonism.
Okay, very good. How we can differentiate between normal pressure hydrocephalus and Parkinson in the gait?
The normal pressure hydrocephalus, you have ataxic gait. The Parkinson have short shuffling gait,
You mean a taxic gait like cerebellar symptom?
cerebellar symptoms.
No, no. Normal pressure hydrocephalus, there is
لا
what
مش
we.
cerebellar، مبقاش عنده cerebellar symptoms، بس المريض بيبقى عنده ataxic gait صح؟
No, 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 no. In a normal pressure hydrocephalus, there is what we call magnetic gait. This is when the
أيوه
patient can't rise
أيوه.
his gait from the ground. But in Parkinson, it is more of in Parkinson plus, it is more of wide based gait, and in Parkinson, it's shuffling gait. Okay.
تاني باركنسون بلس اللي هي المالتي سيستم اتروفي
Yes,
تقصدي؟
yes, yes. Where we
لو هي
have
جت لو
cerebellar.
سيربيلم بريدوميننت، لان هي
Yes,
ممكن تبقى باركنسونيزم دوميننت او سيربيلر دوميننت.
yes, yes, yes. Here we will develop a wide-based case. What other differential diagnosis you may consider here? You mentioned about
in this
Parkinson
urinary
disease itself.
incontinence can be
Yes,
urine infection, can
can
be
be
prostatic
urine
hyperplasia.
infection. You mentioned about multi-system atrophy. Any other Parkinson plus you can suspect in this patient?
Lewy body dementia.
Okay, very good. And anything else?
Vascular dementia.
Vascular dementia as the patient is having risk factors. Okay, very good. Anything
Mm.
else?
Supranuclear gaze palsy, but again, this patient it doesn't have any vertical gaze problem.
Okay, very good, very good. Could be something called what we call corticobasilar degeneration. It is one of the
أيوه.
yes, one of the Parkinson plus, and it is mainly cortical
Mhm.
abnormalities like behavioral changes, apraxia, and so on. Okay, so how would
Mhm.
you like to manage this patient?
This patient need investigation in the term of brain imaging, SPECT scan. We need to run also basic metabolic test for him, a full blood count and blood sugar and thyroid function test, kidney function test, renal function test. We need also to do ultrasound abdomen for his urinary bladder to check for prostate and to check for any to do urine test for any infection. He needs a multidisciplinary team from the neurologist and the speech and language therapy and psychiatrist as well as psychologist as well as urologist. Um, بس يعني
Okay, so how would you like to treat this patient?
uh, um, this patient need non-pharmacological, mainly he needs supportive management in the term of multidisciplinary team for risk of fall need to be precautions need to be taken as well as nutrition as well as swallowing and speech and language therapy team.
Okay,
We need also to give him medication
what
for
medication?
LV-DOPA plus DOPA agonist and carbidopa, and we need also to give him monoamine oxidase inhibitor. Uh,
Okay,
we need also to treat we need also to treat the symptoms for monoamine oxidase inhibitor and entacapone. انت كمان
Okay,
also we can give.
in this age
Mm.
of this patient, will you start him on dopamine agonist, or will you give the dopaminergic drugs itself, the levodopa, carbidopa?
No, I think we will give the dopamine agonist,
No,
I
no.
think.
No, no. In old age after 65, we directly start with levodopa, carbidopa. We do not save it because already the patient is having the symptom and already the patient is having short life expectancy. Before 65 years, we can try the
Mm.
dopamine agonist first before starting the levodopa, carbidopa. So the main treatment here is to start the patient on levodopa, carbidopa. We can use the dopamine agonist as augmentation therapy with the levodopa carbidopa here. If to treat some
يعني
problems
شوفي لو
like on
المريض
and off
لو
phenomena. Yes.
لو المريض قبل 65 سنة بتصبري على الميديكيشن عشان السايد
Yes,
افكت.
yes. No, no, no. Not because of the side effect, because of the duration of the medication. Because after some time, the levodopa will have some resistance. The patient will develop more of on and off phenomena, will not respond as before. So before that, we can start first with the dopamine agonist. But in old age, we already expecting short life expectancy, so we started straight away to improve the lifestyle of the patient. When to add the dopamine agonist, we add it as augmentation to treat the on and off phenomena and to try to prolong the time of levodopa.
يعني انت دلوقتي هتدي للمريض دوبامين اجونست ولا هتدي له ايه؟ مش فاهمة.
Levodopa, carbidopa from the start.
الليفودوبا والكاربيدوبا دول ايه؟ دوبامين.
Yes, not dopamine agonist, not drugs working on dopamine. It is dopamine itself.
ايوه.
Yes.
دوبامين اتسل.
Yes,
تمام تمام.
yes, yes.
فهمت.
The medication itself. About the dopamine agonist, this is can be given as augmentation.
امم.
Okay.
ايوه ايوه.
Like the COMT inhibitor, tolcapone, entacapone, MAO-B
مم،
inhibitor.
مم،
Sometimes
مم.
anticholinergic may be used to decrease tremor, amantadine. Okay, what do you know about the surgical therapies in Parkinson's disease?
ديب برين ستيميوليشن.
Very good.
ايه يا اختي؟ اسمه ايه؟ سلادوتومي ولا اسمه ايه؟
Thalamotomy, thalamotomy and
س-
validotomy. But mainly
ايوه
it's about,
سلادوتومي اند
yes,
فاليدوتومي.
the deep brain stimulation. Okay, if this patient is developing difficulty in swallowing, how would you like to give him the levodopa?
We can give levodopa I think intranasal ولا ايه ده؟
No, no, no. There is a dopa pump can be inserted in gastrostomy if the patient is
ايوه
having difficulty swallowing.
ايوه.
Okay, so
دوبا بامب اوكي.
yes, yes, there is dopa pump. Okay, there is also subcutaneous epomorphin, which is dopamine agonist if the patient is not
ايوه
can't tolerate any oral intake. So this is
ايوه.
important. Epomorphin by name is important to prevent neuroleptic malignant syndrome in patient having Parkinson's disease and will stop taking the oral medication. So we need something subcutaneous. Okay, so this is
أمم.
apomorphin is very important. And the second option in patients having gastrostomy or patient not tolerating oral intake is what we call dopamine pump.
أمم.
Okay, so what do you think is the cause of incontinence in this patient?
It's a part of autonomic dysfunction of Parkinsonism.
Very good, could
However,
be.
it's
Yes,
how
other.
how however it can be benign prostatic hyperplasia, which is common
Very
in
good,
old age.
very good.
Can
Any
be
other?
urine infection. Can be urine infection with any old age. Can
Very
be
good.
urinary bladder overactive bladder.
Very good. And could be functional. Could be functional. Just functional because the patient is having difficulty moving and the patient
أيوة.
can't reach to the bathroom. So
عقبال ما
the
يروح الحمام
yes,
يكون
he lost the control. So the urinary incontinence could be
مم.
stress, and you asked about very good. You asked about the stress incontinence. Could be urge incontinence. What we have here is urge incontinence, more of autonomic dysfunction. The bladder can't tolerate having large amount of urine, and it could be something mixed and could be functional. It is related to the mentation of the patient. The
مم.
patient is developing dementia, and if the patient is having difficulty movement in his
مم.
movement. Okay, so this is
مم.
these are the
مم.
cause. Very good, very good, very good. You did it very well. Thank you.